My name is Amanda Shackle, and it is my pleasure to introduce the second session for the day. We are honored to be joined here by Doctors Deepti Hirshavaranda and Melissa Burns. First, we'll have Dr. Deepti Hirshavaranda. She completed her medical school at Rowan University School of Osteopathic Medicine and then completed her anesthesiology residency, followed by a fellowship in regional anesthesiology and acute pain medicine at Thomas Jefferson University Hospital, where she is now faculty. And she is an important member of the regional anesthesia team. She will be speaking today on regional techniques for breast and thoracic surgery. Please join me in welcoming our distinguished speaker.
Thank you for that introduction. My name is Deepti. I'm one of the faculty at Thomas Jefferson Hospital. I do regional and acute pain there. So today I'll be talking about regional techniques for breast and thoracic surgery, focusing more on breast surgery. There's a lot to cover there. So I have no conflicts of interest to disclose. Some of the objectives, I want to just review the anatomy and innervation of the breast and chest wall, and then talk about the various regional techniques available for breast anesthesia and analgesia, and then go over how to perform these various regional techniques. So to start, breast cancer is one of the most prevalent cancers in women worldwide. There's an estimated 1.7 million women diagnosed annually. And breast surgeries are among the most common operative procedures, and numerous options exist for perioperative anesthesia and analgesia that can affect acute postoperative pain, persistent pain, and potentially cancer recurrence. Over 1/3 of patients who underwent breast cancer surgery have inadequately controlled acute postoperative pain, and they are at high risk of developing chronic pain after these procedures. Up to 55% of post-mastectomy patients experience chronic pain, persisting for months to even years. And one of the best predictors of developing chronic pain following breast surgery is the amount of acute postoperative pain they have. So I wanted to start with the case scenario to think about during the talk. This is a 74-year-old female with end-stage COPD who was recently diagnosed with breast cancer, and she's presenting for a unilateral simple mastectomy. There's a pulmonology consult with high degree of concern for prolonged need for mechanical ventilation following general anesthesia. So I want you to think about what would your anesthetic plan be, and we'll readdress this at the end. Just want to review some of the relevant anatomy and innervation. The majority of the cutaneous sensation of the breast comes from the anterior and lateral branches of the intercostal nerves. The thoracic spinal nerves exit the intervertebral foramen and divide into dorsal and ventral rami. The dorsal rami innervate the skin and muscles of the medial back, and the ventral rami pass through the paravertebral space and become the intercostal nerves, which travel in the intercostal space just below the inferior border of the superior rib it corresponds to. So the innervation of the breast is derived from the branches of the intercostal nerves at the level of T through to T5 with variable involvement at T1 and T6 intercostal nerves. It's important to note the intercostobrachial nerve. That one arises from the T2 intercostal nerve. This nerve travels laterally along the floor of the axilla, and it reaches the upper arm, thus providing cutaneous innervation to the axillary tail of the breast, the axilla, and the medial upper arm. The intercostobrachial nerve is often implicated in post-mastectomy pain, especially after axillary dissection and lymph node sampling. So the brachial plexus supplies the innervations to the muscles of the chest wall other than the intercostal muscles, which are supplied by the intercostal nerves. The pectoralis major muscle is supplied by the lateral and medial pectoral nerves. The pectoralis minor muscle is supplied by the medial pectoral nerve. And these nerves arise from the brachial plexus, the lateral pectoral nerve coming from the lateral cord, and the medial pectoral nerve coming from the medial cord. And the long thoracic nerve innervates the serratus anterior muscle. This arises from the C5 to 7 nerve roots. And this can be disrupted during breast reconstruction and can result in myofascial pain to the chest wall. The thoracodorsal nerve innervates the latissimus dorsi muscle, and this arises from C6 to 8 nerve roots, which can also be disrupted during mastectomy. So just to start with the blocks available, this is the intercostal nerve block. Local anesthetic can be deposited near intercostal nerves to provide a band of anesthesia related to a specific dermatomal area. The problem with this is you need to block multiple intercostal nerves to achieve the coverage for the breast. This can be effective in providing analgesia for breast surgery, but like I said, there are several disadvantages. There's a need for multiple injections. There's an high incidence of incomplete block, and a greater risk of pneumothorax, pulmonary damage, and local anesthetic toxicity. And I want to touch on the PEX blocks. Important to note, recently they changed the nomenclature for this, so it was PEX 1 and 2, but it was a little bit confusing because the PEX 2 block encompassed the PEX 1 block plus a deeper injection, so now they're referred to as superficial and deep pectoral nerve blocks instead. The superficial pectoral nerve block targets the lateral and medial pectoral nerves, and it's an injection between the pec major and minor muscles. And the goal of this injection is to reduce postoperative muscle spasm and myofascial pain from the pectoralis muscles, which can occur from surgeries involving tissue expanders and subpectoral prosthesis placement. And then the deep pectoral nerve block is a deeper injection between the pec minor and serratus anterior muscles. And these target the intercostal nerves, the long thoracic nerve, and the thoracodorsal nerve. So with the previous naming, the superficial pectoral nerve block would be the PEC 1 block, and the deep pectoral nerve block would be the deeper injection involved in the PEC 2 block. So this is just an image to show where you would place the transducer while performing this block. The patient is usually supine. So the superficial pectoral nerve block involves hydrodissection of the plane between the pectoral muscles, and you can inject local anesthetic in this plane. The main landmarks to identify are the pec major, pec minor, and the pectoral branch of the thoracoacromial artery. This nerve block is performed with the patient supine, either with the arm next to the chest or abducted 90 degrees. And as you can see in the ultrasound image, you can see the needle trajectory and the local anesthetic spread in this plane. The deep pectoral nerve block involves depositing local anesthetic between the pec minor and serratus anterior muscle, and this can be done at the level of the fourth rib. The biggest impact of the PEX blocks are their relative ease to perform and potentially low risk profile. And because of the peripheral nature of these blocks, sympathetic blockade is not expected. There is very low risk of serious bleeding, and as with other ultrasound-guided interfascial plane blocks, they can be done safely in both the awake and the anesthetized patient. So moving on to the serratus plane block, this is a variation of the PEX blocks, and the goal here is to provide extended intercostal nerve coverage to the T2 to T9 dermatomes. So this block is performed more distal and lateral than the deep pectoral nerve block, overlying the fifth rib in the mid-axillary line. The latissimus dorsi muscle is visualized with ultrasound overlying the serratus anterior muscle. And to be sure you're in the correct area, you can identify the thoracodorsal artery to verify that you're in the correct plane between the two muscles. Local anesthetic is then deposited here, and it can provide a sensory block to the T2 to T9 dermatomes. The intercostal brachial nerve, lateral cutaneous branches of the intercostal nerves from T3 to T9, and the thoracodorsal nerve are located in this compartment. So changing gears a little bit, thoracic epidurals were once considered to be the standard in providing analgesia following breast surgery, but it's now been overtaken by other relatively easier techniques. The most common levels to insert a thoracic epidural to cover the breast would be between T3 to T5. And this would allow local anesthetic to be introduced into the epidural space to achieve blockage of nerve roots from the 2nd to 8th thoracic segments. This would then cover the axillary area along with the chest wall. The block is usually bilateral and can provide analgesia for several days. But similar to intercostal blocks, the thoracic epidural without cervical spread will not block nerves arising from the brachial plexus, and like I said before, they can contribute to a lot of the pain that these patients experience after breast surgery. Thoracic epidurals are no longer routinely used as they may delay patient discharge. There's a high failure rate. Placement can be pretty challenging at this level, and there can be major complications, and several absolute and relative contraindications exist. So although the evidence supports the ability of epidural technique to provide both surgical anesthesia and postoperative analgesia, there are concerns regarding adverse events, and it's prevented this technique from becoming common practice in breast surgery, anesthesia, and analgesia. If you look at the top table, there are several complications listed, including post-dural puncture headache, epidural hematoma, epidural abscess, total spinal, subdural block, prolonged neurologic deficit, and failure. And you can see the incidence to the right. There are also several absolute and relative contraindications, and these include coagulopathy, therapeutic anticoagulation, thrombocytopenia, sepsis, and many more. So while we all know the risks of thoracic epidural, there still might be a role for this in prolonged flap reconstructions. So moving on to the paravertebral block, the thoracic paravertebral space is a wedge-shaped space located on either side of the vertebral column. Anterolaterally, it is bound by the parietal pleura. Posterior border is formed by the superior costotransverse ligament, and the base of the wedge is formed by the posterolateral surface of the vertebral body. So the paravertebral space can be accessed to block the thoracic spinal nerves as they exit the intervertebral foramen. Local anesthetic deposit in this space can spread multiple levels, as shown by the figure here, and multiple levels both superiorly and inferiorly, as well as the intercostal space laterally and the epidural space medially. And this results in a blockade that is sensory, motor, and sympathetic. And local anesthetic typically covers about 5 to 6 dermatomes. This technique generally results in ipsilateral blockade of the somatic and sympathetic nerves and can serve as the sole anesthetic for breast surgery as long as the blockade of the pectoral nerves or other branches of the brachial plexus are not required. The literature supports paravertebral as an effective perioperative analgesic technique for breast surgery, and it can provide surgical anesthesia as well as decrease nausea and vomiting, hospital stay, and chronic post-surgical pain. But similar to epidurals, the safety of paravertebral blocks for outpatient surgery is a concern, although it would have less of a sympathectomy than the epidural. So how do we perform the paravertebral? There are 2 ways to do this. One is by landmark technique, and the other is using ultrasound. The classic landmark technique is described as perpendicular advancement of a needle 2.5 to 3 centimeters lateral to the spinous process. And upon contact with the transverse process, the needle is walked off the bone until loss of resistance to constant pressure of the column of saline is observed. And as you can see from the table, there are several potential complications, including hypotension, vascular puncture, accidental pleural puncture, and pneumothorax. And as you can see, the incidence is much higher with the landmark technique than with ultrasound. So there are 2 ways to scan using the ultrasound for the paravertebral. So this is the transverse scanning technique. And here the ultrasound transducer is positioned lateral to the spinous process with the orientation marker directed to the right side of the patient. And here, as you can see in the ultrasound image and in the drawing, the paraspinal muscles are clearly defined and they lie superficial to the transverse process. And here the transverse process is seen by hyperechoic structure. In the figure that I have, there's a shadow, so it's not quite hyperechoic, but usually it can be seen as hyperechoic. And you'll also see the pleura as a hyperechoic line moving with respiration. The paravertebral space is actually not seen quite well due to the shadow from the transverse process, but you can see the hyperechoic space between the parietal pleura and the lateral costotransverse ligament, and that represents the apex of the paravertebral space, so that's where you would inject local anesthetic. I personally find this a much harder way to obtain the view, especially with the shadow from the transverse process. So this is not how I usually perform a paravertebral block. I usually do the sagittal scanning technique. So here the ultrasound transducer is positioned 2 to 3 centimeters lateral to midline with the orientation marker directed cranially. And the transverse process is seen as hyperechoic structure, and it's deep to the paraspinal muscles. And in between the 2 adjacent transverse processes, you can see the superior costotransverse ligament, the paravertebral space, and the pleura. And local anesthetic is deposited deep to the superior costotransverse ligament. It's important to note that before I mentioned you can get 5 to 6 dermatomal spread with a single injection, but some do like to perform 2 to 3 injections to ensure coverage to the whole area. The last block I want to go over is the erector spinae plane block. The erector spinae comprises a group of muscles, including the iliocostalis, longissimus, and spinalis muscles, and they run bilaterally from the skull to the pelvis and sacral region, and from the spinous process to the transverse processes extending to the ribs. Now, the mechanism of this block is not completely understood, as it's still a relatively new block, but some studies suggest that there's anterior diffusion of local anesthetic into the paravertebral space, although an interfascial spread toward the dorsal and ventral rami is probably the main mechanism of action. And it's important to note here that it's considered a peripheral nerve block, so you don't really have to worry about when the patients are on anticoagulation or if they have any lab values that are abnormal. So then first you would select your target transverse process, and you place the transducer similar to the last paravertebral technique in a paramedian sagittal orientation, again 2 centimeters away from midline, and you visualize the transverse process on ultrasound. And you will see all 3 layers of the erector spinae muscles and the rib transverse process complex and the paravertebral space again. And here you'll insert the needle in plane from cranial to caudal and inject local anesthetic in the plane deep to the erector spinae muscles, superficial to the transverse process. And you will get cranial caudal distribution of local anesthetic across several vertebral levels. So I just wanted to touch a little bit on some of the data. This is a retrospective study that found that substituting surgical infiltration with multi-level injection at either the paravertebral or erector spinae, it resulted in significantly shorter length of stay and potentially improved pain outcomes after mastectomy with flap reconstruction. And there were actually similar reductions in length of stay observed with both the blocks. So paravertebral and erector spinae blocks are definitely a more favorable technique than local infiltration from the surgeon for the perioperative pain management. And I mentioned this earlier on, just wanted to touch on cancer recurrence. There is some evidence pointing towards regional anesthesia to reduce cancer rates and metastasis, but it's still a pretty understudied area, and much more research needs to be done. But the hypothesized mechanism would be through an anti-inflammatory effect and reduction of surgical stress, or a reduction in the concentrations of growth factors. But like I said, a lot more studies need to be conducted. So I covered mostly the blocks for breast surgery, but these can also be applied to thoracic surgery. This is an algorithm that was proposed in 2021 as a guideline for VATS. And as you can see, they recommend a paravertebral or erector spinae plain block with the catheter. And if either of these are contraindicated, they recommend a serratus anterior plain block. And then for open thoracotomy, they recommend a paravertebral catheter, although a thoracic epidural can be done as well. And if either of these are contraindicated, an erector spinae plain catheter is then recommended. So back to the case scenario. So 74-year-old female with end-stage COPD, diagnosed with breast cancer, presenting for unilateral mastectomy. This was actually a patient of mine. The pulmonologist had written in the chart, if you intubate her, she will not get extubated. So, and literally those words. So we all met together with the surgeon and the patient and came up with a plan, decided to do a multi-level injection, a paravertebral injection at T2 and T4. The problem here was she was very frail and only 40 kilos, so we didn't have much room to inject a lot of local anesthetic. So we did 10 mLs of 0.5% ropivacaine at both levels. And she actually did pretty well. We had to sedate her with ketamine and dexmedetomidine. And since it was a simple mastectomy, I think we got away without doing PEX block. But if she had needed tissue expanders or something, I think we would have needed to add that. And because of her weight, I don't know if we really would have been able to get as much of a dense block without injecting the appropriate amount of volume. But she did really well. We avoided intubation. She was actually discharged the next day and very grateful to us. So, and that's all I have. Thank you.
Thank you so much for that excellent presentation. Our next speaker is Dr. Melissa Burns. She received her osteopathic degree from Michigan State University. College of Osteopathic Medicine, and holds a master's in public health from the University of North Carolina, Chapel Hill. Following graduation from anesthesiology residency at the University of Michigan, she took a position in private practice in Williamsburg, Virginia, and then returned to the University of Michigan for fellowship training in regional and ambulatory anesthesia, where she has remained until recently, and now she currently holds rank of clinical associate professor in the Department of Anesthesiology at UVA Health in Charlottesville, and is the director there of the point of care ultrasound. She will be speaking today on excellence in regional anesthesia, ensuring safety and quality. Please join me in welcoming Dr. Burns.
Thank you so much, Dr. Shackle, for that lovely introduction. I'm really excited to talk to you about safety and quality specific to regional anesthesia. I'll start by saying I have no formal conflicts of interest, and I do want to recognize that there are many products that I will be mentioning, but these do not represent any sort of endorsement or recommendation on my part. Here are my learning objectives, but I think I'll just jump right in. I first want to talk about wrong-sided nerve blocks. And the short answer is, we should never do it. But the fact remains that they do occur at an incidence of about 7.5 cases of wrong-sided nerve blocks per every 10,000 blocks that are performed. And just for a frame of reference, this is over twice the rate of experiencing anaphylaxis under general anesthesia. Now, of course, this may be an underestimate, usually because of underreporting, when there's no adverse consequence to a wrong-sided nerve block. But really, these should become never events. And this has been endorsed by the National Quality Forum that is funded by CMS. Now, as we all know, it is a serious reportable event if a patient has surgery on the wrong limb or the wrong side. And this pertains to wrong-sided nerve blocks as well. Honestly, I see this as a great example of James Reason's Swiss cheese model, and often RCAs are conducted in the setting of wrong-sided nerve blocks. There are a number of contributing factors, and just looking at our environment, I would say the one that draws my attention most is that of distraction. Distraction at the time of a block should always be minimized, but we all know the fact is that we get pages, we get calls. I have a Vocera that goes off nonstop all day. There's teaching that goes on. There's people that come in and out of the room. Nurses may be taking breaks. Not to mention that if there's a change in the patient condition, the patient desats and we need to put oxygen on, this can draw our attention away from the side that should be properly blocked. Additionally, there's a number of block or technical factors. Perhaps it's repositioning, you're doing more than one block, or maybe it's just challenging anatomy that takes an additional amount of time. And we're all understanding that time pressure, especially in regional anesthesia, is always working against us. So just to give you an example case, this is taken from the literature, of a 56-year-old woman who came in for a right-sided ankle fusion. She'd had rheumatoid arthritis, and the plan for her anesthetic had been a right-sided adductor canal block in the supine position. Now, this next image gives you a visual representation of the location of the ultrasound machine on the patient's left and the operator on the patient's surgical side. So the patient undergoes an AC block, supine, goes well. At this point, though, they reposition the patient into the prone position for an infragluteal sciatic block. But what had happened is the ultrasound remained on the patient's left side and the provider on the patient's right side. There were two providers in the room, and they both agreed to scan what they thought was the surgical limb. They were having some trouble identifying the sciatic nerve, so they decided to scan more distally, at which point the second person in the room recognized that the patient had a sock on the side where they were blocking, and they had realized that they had taken off the surgical sock prior to initiating the right-sided AC block. So this is just an environmental cue that thankfully led to the block being performed on the correct side. There's a number of different checklists or ways in which we can prevent wrong-sided nerve blocks. This is known as the stop before you block, taken from AOCA, and essentially it just means we all are quiet, we prep, we stop before we actually block, confirm the right side, and then perform a block. ASRA Pain Medicine has also put out a checklist. It's a bit lengthier, and it's comprised upon evidence-based data. And there's 9 different steps associated with it, as well as an app that you can download to your phone that allows you to click each of these steps as they're performed. What I like about this is that it also allows for you to repeat this checklist if you reposition or perform a secondary block. And then another option promoted by the Association of Anesthetists is based on cognitive psychology theory known as the mock before you block. So you would perform the stop before you block, and then you would take an empty syringe and essentially pretend to block the side, at which point a second person in the room will confirm that this is the correct side for the intended block, and then the actual block is performed. All in all, you can see that there's a number of things we need to take away from wrong-sided nerve blocks, second providers to witness the consent and that things are done appropriately, and most importantly, a speak up for safety culture. Next, I want to talk about nerve injury. And it's important that we think about incidents. The closed claims database from 1990 demonstrated that 21% of all non-obstetric regional claims involved peripheral nerve injury, with the vast majority of these being temporary nerve injury, but of course there were some more serious events. Who is at increased risk? I think we're all aware that patients with pre-existing neuropathy present a higher risk, but also those who are obese or with a smoking history, and then patients having upper limb blocks have a higher risk. There's a number of reasons why this may occur. I don't want to spend all day talking about pathophysiology, but basically nerve injury theory rests upon the two-hit hypothesis, right? That more than one insult is more necessary to cause damage. This is a nice study by O'Flaherty and colleagues where they looked at the claims associated with death or brain damage and noted that the majority of these claims related to intravascular injection or absorption, and cardiac, general, orthopedic, and neurosurgical procedures all had a much higher risk. The real takeaway, though, is that peripheral nerve injury is 9 times more likely to be a result of factors related to the surgery or the patient than actually related to the nerve block itself. Again, AOCA has an algorithm in the event you experience unexpected or persistent neurologic dysfunction that I encourage you to review. And ASRA has issued practice guidelines from 2008, headed by then President Dr. Joe Neal. In these guidelines, they deduce some strategies for reducing nerve injury, a few that I will touch on. So there's always a long-running debate of whether we should be performing these blocks in awake patients or whether it's okay to perform in asleep, with the gold standard having been, well, if a patient's awake, they can report pain or paresthesias or maybe even symptoms of LAST. The procedure then can be halted and we can prevent subsequent injury. In fact, the updated ASRA practice guidelines continue to recommend avoiding regional in patients who are anesthetized or heavily sedated, except where the benefits of having a cooperative patient or an immobile patient would outweigh those risks. And I think we can all imagine that for patients who are pediatric or patients who are not able to sit still during a block, perhaps there is some indication for performing these blocks asleep. We should be using short bevel needles rather than larger bevel needles to avoid injury to the fascicle, as well as the opportunity to use echogenic needles, like you can see here, that decrease your procedural time and also more easily visible when you're working with less experienced operators. This study is meant to suggest that when it comes down to local anesthetic, we need to go as low as we can go. In the sense we should be using low volumes and low concentrations in order to get our patients that desired analgesic benefit, but not put them at risk of toxicity. And then, of course, there are adjuvants. I would advocate that the doses that are currently used in clinical practice for dexamethasone, clonidine, or dexmedetomidine are likely safe at the given doses. Now, the pendulum forever swings regarding the use of nerve stim. In fact, I work every day with trainees, whether they're residents or fellows, maybe even colleagues, who go and rip the stim needle or the stim lead off of the needles that we use. And I ask if that's really the best idea. And I say that with regards to nerve injury in the sense that there are many blocks that we do, in particular the interscalene nerve block, where the risk of causing nerve injury to nerves that we're not necessarily intending to block, like the dorsal scapular and long thoracic, may come in the field or the trajectory of our needle tip. Many have actually advocated that we use a combination of 3 monitors: ultrasound, nerve stim, and injection pressure monitoring in order to prevent nerve injury. And you can see here the compressed air injection technique, as well as an example of an inline disposable pressure manometer specifically designed for pressure injection monitoring. I'd be remiss if I didn't speak at least one slide about our vigilance and attention when patients are anticoagulation, but of course this could be a whole talk in and of itself. I next want to talk about local anesthetic toxicity, just briefly, and how we can prevent it from happening. And again, just to give you some idea about relative incidence, it's very similar to the likelihood of encountering anaphylaxis. This is a nice image taken from toxicology flashcards, but it anthropomorphizes the symptoms of LAST as well as toxicity risk factors. Here you can see that as the serum concentration of a local anesthetic increases, we're more likely to have more serious side effects and complications like respiratory arrest. But please recognize that patients can present anywhere along this continuum, even with delayed presentation upwards of 30 to 60 minutes after injection. Also be alert to EKG changes. Commonly, you'll see widening of the PR interval, bradycardia, progressing to VTAC, VFib, or even asystole. I don't want to get into exact dosing or exact max dosing of local anesthetics because there's so much information out there and there's not any concurrence across countries, across societies of what the max dose is. But recognize that there is a max dose and we probably should be following along with the most conservative guidance. This is a nice study from Mayo that was recently published where they looked at the dosing of local anesthetics in total knee arthroplasty. Now, as we're all aware, total knee arthroplasty is one of the most painful surgeries that patients have, so anything we can do to improve their mobilization and decrease opioid requirements is a good thing. People have advocated for peripheral nerve blocks in conjunction with periarticular injections because those help to get the patient moving with less pain. What this study demonstrated is that in a retrospective review of almost 4,500 patients, the median dose of local anesthetic between periarticular infiltration and their nerve block was almost 1.5 times the suggested maximum. Thankfully, they had no definitive cases of LAST amongst that population. As we're aware, lipid emulsion therapy is the mainstay of treatment for LAST, and I encourage you to have access to a Stanford manual or checklist for management should the need arise. And of course, ASRA also has an app available to walk you through the critical steps, including noting the decreased dosing of epinephrine and favorability of amiodarone for ventricular arrhythmias. When all is said and done, we want to use the lowest dose, we want to inject incrementally, aspirating regularly, and be aware of the additive effects. Furthermore, I think the conversation about the total dosing is something that we can actively manage from pre-op through post-op recovery for these patients. Next, I want to talk about image optimization. We all know there's a benefit to using ultrasound. It shortens the block time performance. It's more comfortable for patients. There are fewer needle redirections. But again, another longstanding debate is, should we be performing blocks in plane or can we do them out of plane? And really, there's few data to recommend superiority of either. This is a study where they looked at the onset and recovery of interscalene blocks for shoulder surgery using an out-of-plane approach. And what they found is that out-of-plane led to decreased performance time as well as faster onset of both sensory and motor blockade. A study by Dr. Schwenk noted that for patients who are having a catheter placed for shoulder surgery, that there was no superior analgesic benefit to an out-of-plane approach, but there were also no increased complications. And so for certain patients, perhaps based on body habitus, it is safe to use an out-of-plane approach without any given concerns for the patients. So circling back to whether you should use nerve stim, I've talked about nerve injury, but obviously my answer is yes. And there's additional reasons why. And that would be that for patients who have unclear sonoanatomy, patients who are having blocks at a deeper level, or even with inexperienced operators, these are beneficial to use nerve stim. For example, an axillary brachial plexus block. Here in this image, we can clearly see the median nerve, but we're not able to see the ulnar, the musculocutaneous, and the arrow is pointing to what's likely the radial nerve, but could potentially be confused with post-cystic enhancement deep to the axillary artery. You can imagine using peripheral nerve stimulation can help you to identify where the nerves are, have your block set up faster, and improve the likelihood of success with a surgical anesthetic. Next, I want to talk about ergonomics, and this is something I like to spend time with our trainees, because this is really just a developing area of anesthetic practice, but really important, with the general principles being adjust the bed height appropriately and align the screen so that it is directly aligned with the block, all in one line of view. You can see a few images here. This just does not look comfortable, right? We're stretching over, we have some flexion, we have some significant neck extension. The chance that you're going to be able to perform a block easily is going to be hindered with these types of positioning. A study by Spear and colleagues looked at 2 ways you can position your hands in relationship to your visual axis. On the left of the screen, you can see the along the visual axis, or ELVA method, where the operator, the needle transducer, and monitor are in a linear line. In contrast to the across the visual axis, where the needle and transducer are 90 degrees to the operator. As I'm sure you can suspect, in novice operators, using the along the visual axis technique minimizes the need for needle redirection and reduces the time to perform the procedure, let alone improves ergonomic comfort. So here we can see an axillary block, a supraclavicular and interscalene block, and a femoral block, all with this along the visual axis approach. There have been attempts to use other technology, including head-mounted displays, and you can see here that the camera is on the operator's glass, so they don't even have to look up at a monitor. In fact, Google Glasses have been proposed as an option for this type of performance of nerve blocks. And then lastly, let's just touch on AI, again, a whole topic in and of itself. So this is a nice study out of the UK where they looked at assessing the performance of an assistive AI system in aiding the identification of anatomical structures on ultrasound imaging. It is impressive to see that AI was able to highlight and identify specific anatomical structures in 99.7% of cases and was able to confirm the operator had obtained the correct ultrasound view in 99.3% of images. So yes, there's many future applications of AI, whether it's machine learning, predictive models, of need for nerve blocks, but I can see it most beneficial in the future, the near future, in teaching applications. Let's move on to some safe practices we can adopt on a regular basis. So unfortunately, wrong drug, wrong route, medication errors can occur to any individual in this room. And this is a study by former President Eugene Viscusi of Azra Pain Medicine looking at the rate of these events. This image is just meant to show you that the number of medications that were inadvertently injected wrong route can range from antibiotics to muscle relaxants, contrast agents, and a number of other types of medications. And while wrong route errors continue to occur, despite our repeated warnings, it's up to us to be vigilant to prevent this. The World Health Organization went so far in 2022 to draw attention to reports of tranexamic acid that was being injected intrathecally for obstetric spinal anesthesia. Now, this comes with a 50% mortality rate and significant morbidity to those who survive. This very recent newsletter from the APSF also addressed the inadvertent administration of tranexamic for bupivacaine intrathecally for a patient presenting for a total knee. The APSF has advocated that pre-mixed bags can be the single most effective measure to avoid these wrong drug, wrong route administering errors. As you can imagine, this really falls upon things we can do within our organizations to improve system reliability. And while they're the hardest to implement, they are the most effective. Another option is to consider options for how we change the connectors that we use in order to prevent these wrong route administrations. In 2016, an ISO-compliant neuraxial connector that you see here was introduced. What's clearly visible is that the color is different, it's yellow, but what you may not also notice is that the diameter of the connector is smaller. Therefore, it should be less likely that you could take a medication intended for intrathecal or epidural administration and put it either IV or vice versa. Next, I want to talk about the importance of avoiding bacterial contamination. And yes, the incidence with peripheral nerve blocks in single shot form is quite low, but the incidence for patients who have a continuous catheter, one, increases with duration the catheter is in place and can be as high as 30 per 10,000 events. This is an interesting article taken place in an Australian ED where they swabbed the ultrasound machines in their emergency department and noted that almost 60% of them had blood contamination, but to the visible eye, only 50% were noted to have blood. And to me, that's just kind of gross. So to that end, many are advocating for the use of dedicated or single-use sterile transducer covers. It's also been drawn to attention that these really should cover not just the probe itself, but also the cable. These may help to reduce contamination levels, as well as the opportunity to use single-use sterile gel packets as opposed to like a bottle that can have cross-contamination risk. Now, I'd be remiss if I didn't talk a little bit about point-of-care ultrasound, and even to the college, I've talked a bit about the use of point-of-care ultrasound and its benefits to regional anesthesia in the past. I'd mentioned that, with many of the upper extremity blocks, there is a risk of phrenic nerve paresis. In fact, with the interscalene block, as we know, it's 100% risk. But we can use ultrasound then to evaluate a patient's risk and their diaphragmatic function. For many patients, I've adopted this scanning algorithm. One, it helps to teach trainees about the benefits of using POCUS, but also to be able to identify what does phrenic nerve palsy look like and how can we ensure that our patients don't have it on the contralateral side of an interscalene nerve block. And so before we do a right-sided nerve block, for example, we'll scan the left diaphragm to ensure that we can see diaphragmatic movement. Additionally, we should be evaluating for the risk of pneumothorax. This is an image of lung sliding. And as you can imagine, when we perform certain blocks, and this can include things like ESPs, paravertebrals, PEX blocks, as well as our blocks above the clavicle, there's always a risk of encountering the lung. And as you can see here, it doesn't take a difficult view to recognize that just a tiny slip of that or advance of the needle off the first rib could lead to an unintentional pneumothorax. We also can use ultrasound to look at IVC evaluation to assess a patient's potential fluid responsiveness or current volemic state. So this is a patient who is normal volemic, and we can see that there's some collapsibility of the IVC. Compare that to the patient on the left, who has a much smaller, more collapsible IVC, suggesting a hypovolemic state. Then look at the patient on the right, where you can see the IVC is much more distended, and perhaps a fluid bolus could be detrimental to this patient in fluid or volume overload. A recent study has looked at using this technology to predict post-induction hypotension, and as you can see, looking at the collapsibility index can be a strong predictor of that metric. Now, for my particular practice, I think about patients who are coming in for ambulatory day surgery and understanding what the risk of post-induction hypotension is, specifically for patients coming in for arthroscopic shoulder surgery who are going to be in the beach chair position. And I think we'll start to see more and more information related to how we can use IVC assessment for these patients. Lastly, as relates to POCUS, we're seeing a lot of fragility fractures. I know this is not just isolated to any area of the country, but using point-of-care ultrasound in this patient population has considerable benefit. It is crazy to think that almost 1/3 of the patients coming in with a hip fracture may not have an appreciable murmur, but may have aortic stenosis. So we can look at peristernal or subcostal windows and identify a calcific aortic valve and perhaps change the management for these patients to avoid a sympathectomy of a spinal or perhaps warrant additional cardiology consultation. So lastly, I just want to summarize how all of this fits together. And many, including Ed Mariano, have advocated that we think about regional from a very tailored approach, and that not one-size-fits-all mentality is appropriate for patients presenting and needing regional anesthesia. There are patients who are going to be higher risk for chronic post-op pain, and your approaches to them in choosing a regional anesthetic should be very different to someone who is less likely to have pain. But I want to think about this not just in analgesic benefits, but rather than just looking at analgesic outcomes, we think about how tailored approaches can really promote safety by identifying those patients who are at risk for potential complications and then adopting strategies in our daily practice to mitigate these risks. At an organizational level, we can adopt a number of approaches, one of which that's been advocated is that of parallel processing models. So we can look at OR scheduling. We can talk about what cases are going in what particular order to minimize the time pressure on regionalists who may be, running 3 rooms with trainees, right-sided, left-sided. In order to prevent injury or promote safety, we can think about how we can stagger cases, whether it's between 2 rooms, or we could have a local case followed by a regional case and a local case to decrease that time pressure and give us opportunity to be successful. Another important parallel processing model is going to be the use of a block room, where individuals who work together on a regular basis will be in presence together, recognizing that those checklists, the stop before you block or the mock block, are used in current day-to-day practice and can prevent wrong-sided nerve blocks. I think it's also important we think about skill development and retention. And I think it's important we think about this outside of training. Whether you're a resident or a fellow, competence and assessment applies to all of us. And maintenance of competency is another important aspect. Most people recognize that 28 blocks with supervision and with feedback are necessary to lead most individuals to obtaining competence. But this is highly variable based on block type, based on personal ability. And I think we need to recognize that with the increasing number of blocks, we need to have a means of evaluating whether people in our department are going to be doing what is safest for patients. And then follow-up. And this occurs not just at the institutional level with QA documentation, but also consideration of national or international registries. The incidence of rare events needs to be reported, even near-miss events like wrong-sided nerve blocks. Let's think about the risks of nerve injury. Let's make sure we're appropriately documenting cases of local anesthetic systemic toxicity. But I think this can be extended to other factors, including, is the patient getting an analgesic benefit after block resolution? Is there rebound pain? Are there episodes of unplanned medical contact after that individual leaves the boundaries of a hospital? And what is our patient satisfaction rate? All in all, I think this just demonstrates that as organizations, we need to shift from a safety climate to a safety culture. Now, a safety climate is the perceived value placed on safety within your organization. I like to think of it as the organization's mood, but this is just a snapshot in time, and it can change on a regular basis. In contrast, the safety culture is more of the personality of your organization. Is this an organization where individuals feel that it is safe for them to report near miss or errors? And promoting a safety culture is where organizations need to start. We have to shift from blame and shame, right, to improve reporting in what's known as a just culture. So thank you all for your attention today. This is a quick summary of the information I hope that you've garnered, and I hope you've gotten some insight into the topics that I think are really key to promoting safety in regional anesthesia. Thank you.
Okay, thank you so much, Dr. Burns. We're going to now move to the question and answer portion. If you have a question for one of our distinguished speakers, I believe we are going to have you raise your hand and a microphone will be brought to you. We can go ahead if anybody has any questions, would like to start off. I think they're going to bring you the mic here in just a second. Go ahead.
Dr. Harshavaganda, what is your experience with bilateral catheters for either bilateral breast surgery or midline cases? And does it logistically work in your institution, and is it effective enough given the dosing considerations?
We don't usually have too many bilateral procedures for breast surgery, but for our hysterectomies, we usually do an epidural for those. And there's some patients who are on some anticoagulation, so then we'll do a bilateral erector spinae plane block. And actually, they've worked pretty well. They actually do get a lot of anterior coverage from the erector spinae. Logistically, it can be a little bit challenging because, well, it's easier to do when these patients are awake, and the surgeon needs to have them signed in and ready to go before we can start. So no matter what, doing 2 erector spinae catheters will take at least 20 minutes if I'm doing it. If a resident's doing it, upwards of 30 minutes. So it's really hard to coordinate that and be in the room on time if the surgeon hasn't done all of their check-ins early. So while it is doable and we do it pretty much all the time, we usually have a delay in the room then.
Yeah, I just have a question about as you were discussing the bilateral erector spinae with catheters. Is anybody using Exparel in the erector spinae block, since it's kind of a volume block, and maybe not doing catheters?
At our institution, we don't have Exparel. I would have to review the literature. I'm not sure if people have been using Exparel in erector spinae, but that would be interesting because you do need a high volume to get the spread across the multiple levels. So I'm not 100% sure.
I did not use liposomal bupivacaine on a regular basis.
I have a follow-up question. So for most of your mastectomy cases, are you doing perivertebral block or erector spinae? Are you doing catheters? And why pick one versus the other?
Interestingly enough, our breast surgeons don't allow us to do regional for most of our cases. It was really just this one patient who had this big reason not to do general anesthesia. We've had several discussions with them about the literature. It's their own literature, too, that recommends doing blocks. But if I had my choice, I would, as long as there were no contraindications like with anticoagulation, I would prefer a perivertebral block plus a superficial pectoral block to cover both the muscle, cutaneous, and sympathetic. I will say the erector spinae, the few times that we have done erector spinae, they do get pretty good coverage, but a perivertebral will get a much denser block.
This is a comment or question for Deepti. As you just mentioned, most of our surgeons don't allow this. So and it sounds like we've done what we can to talk to them about it. I know they can be difficult. Do you know how a regional anesthesia team performing blocks for breast surgery compares to a surgeon performing blocks? And I don't mean just local infiltration by the surgeon.
I don't have a data number for you off the top of my head, but from personal experience, I have noted that whenever we have done a perivertebral block for mastectomy, the patient, I will go see them in the morning and they'll have 0 out of 10 pain and they'll be discharged in less than 24 hours. But when they haven't had any regional, they do complain of a lot of acute pain afterwards. And I'm not 100% sure how the surgeon, that they'll say that they'll do an intercostal block, and I'm not really sure how they do that intraoperatively and get the correct plane without it leaking out. So I don't know 100% like how they're guaranteeing they're getting an intercostal nerve block when they're doing it.
Right, I mean, that's what they're telling me. Oh, I do my own blocks. And I'm not in there the whole time, but when I'm in there, I've not seen the surgeon do their own blocks. And my personal opinion is that you guys' blocks are a lot better. But it's just, I don't know how we get the surgeons on board. That's a problem.
Yeah, we've had like several discussions with them. They were on board for maybe a few months after that last group discussion and then went right back to, and I think it's mainly a time constraint. They don't want us to wait. And if as long as they sign the patient in on time, we'll do this in less than 10 minutes. But usually it's a factor of everyone comes late to the holding area, everyone sees the patient late, and then we're rushed to do the block, and then last minute they'll be like, never mind, we don't want one. So.
Yeah, and that's very unfortunate. And I just had a comment for Dr. Burns. When you were talking about nerve injury from our blocks, and you did mention on your one slide, consider tourniquet. And I have personal experience with that because 2 years ago I had my bunions done and I had single shot adductor and popliteal catheter. And I never had to take a single narcotic. And they break the big toe and move it over. And I mean, you could see by the swelling I had that it would have been really, really painful. But my problem was I developed really bad neuropathic pain down the lateral aspect of my calf and the surgeon, of course, said, oh, it's the nerve block. And I said, it is not during the sural nerve distribution. It is common perineal. And what is there? I have a prominent fibular head, and they didn't put the tourniquet up here. They put it down here. And so I didn't figure that out till I was having the second one, and I had the exact same thing with both of them. And it was by far and away much more painful. I mean, that neuropathic pain was just terrible, and it made my experience so much worse than it had to be because of that. But the nerve blocks were phenomenal.
Yeah, I would say this is the real challenge in regional anesthesia, is that for the majority of our patients, we don't go home with them. We don't see what happens when they leave our ambulatory surgery centers. And this is why I would be a strong advocate for how can we improve follow-up for our patients, because these conversations like you had with your surgeon happen every single day. And regrettably, nerve blocks are being blamed for things that, as the data has demonstrated, it's more likely to be related to surgical factors or the patient themselves than the performance of a nerve block. So how do we best, discuss these things with our surgical colleagues? Well, I would say, it's really important that even if it's just on an annual basis, that regionalist surgeons meet to talk about these potentially related nerve injuries, to have some conversations about what is the likelihood this is related to a nerve block. And please, are you attributing, patient complaints to anesthesia? Because honestly, as a physician, if I knew that I had caused injury, I would want to be able to reach out.
Of course.
And I feel that sometimes we are left out of that conversation with the patient.
100%. And I had to go back a year later and get 2 screws out, which was no big deal, but I told my surgeon, do not put a tourniquet on, and if you do, put it up here. But I don't honestly think that he's changed his practice for anyone else, and that's a problem.
I want to piggyback on that question for Dr. Burns. Is there, does your institution or have you seen in practice like follow-up post-nerve blocks, whether that's, sending patients home with continuous nerve blocks or just even single shots, if they go home, is there a phone call that's done? Is there a check-in or a phone number that they're provided to call if they have an issue?
Sure. So my previous institution, especially for continuous catheters, the trainees were expected to call the patients for 3 days. And that's typically because that was the duration of time we would leave the catheter in place. But what happens at that 1 week mark? We just have no data and we have no follow-up on that.
In the current setting, the trainees, the residents or fellows who perform a block, even a single shot nerve block, are expected to document in the medical record within 1 week that they've had a conversation. But as we all know, patients don't always answer their phone. And so I would say that the overwhelming majority of times where there is an issue, it ends up being filtered through the surgeon to us.
I have a question for Dr. Hashivardhana. I know you didn't talk about rib fractures, rib plating, but I am not ultrasound trained, and I have struggled many times with a patient, elderly, frail, with rib fractures, either from a trauma or whatever, and had been asked to go put a thoracic epidural in for pain relief in the ICU. And I can tell you most of the time that does not go well. What blocks would you do for either rib plating, before rib plating, either for pre-op pain and then after rib plating in, say, a 70-year-old that has rib fractures, either from a trauma or osteoporosis or whatever reason fell and broke ribs?
Yeah, as all these blocks that I talked about can be applied to rib fractures as well. Unless they're bilateral fractures, I usually don't place an epidural. So, and also I check the CT scan or X-ray to see if it's anterior, lateral, posterior fracture. But usually, if we can, we'll try to put a paravertebral catheter in. And then if not a paravertebral, at least if it's a posterior fracture, then we can put an erector spinae catheter as well. And sometimes if there's multiple fractures, like across the whole, like more than like 5 fractures, then we can even do 2 catheters, one superior, one inferior. Yeah, if they're able to sit up, that would be ideal. But we have done them laterally. It's quite challenging because they don't want to stay in that position. But luckily, you know, Bonnie, our block nurse, she really gets them into position and holds them there. If needed, give them some sort of oral pain medicine before starting, but usually they tolerate it fine. And laterals, they'll be able to stay laterally at least. So it's not ideal to do the block laterally, but
I was just going to say to try and, it's hard to get the surgeons to allow us to do the blocks in some cases. I was at a center that did a lot of breasts, and we ended up with a young surgeon who was willing to allow us to do them. So a couple of us who did paravertebrals for the breast prior to the erector spinae, and they were sending them home after a while that day. And that kind of caught on with the other surgeons who then allowed the other blocks because they saw, oh, same day discharges. Since then, we kind of switched over to erector spinae blocks, and I think they seem to be as effective. They take longer to kick in, you'll notice that. But the same thing, we'll send them home on the same day with erector spinae blocks. And I think that's how we got the breast surgeons at least to convert over. As far as the orthopods, just did them when he wasn't looking, didn't slow him down, and that's how that eventually caught on.
I have another question for Dr. Burns. You mentioned local anesthetic toxicity, and you specifically mentioned like a really common patient group that's susceptible to this are the patients undergoing total joint arthroplasty, especially like total knee. Because in a lot of cases we're doing a spinal and then the surgeon wants to do an inter-articular injection, and then they may want us to do either a single shot nerve block or even a catheter. How do we balance like all the different amounts of local that we're using and ensure that we're, you know, well below the toxic level, and how do we account for all those different injections?
Well, the interesting thing about that Mayo study is they didn't include the intrathecal dosing. So they ended up at 1.5 times, right, our expected max dosing. Although the max dosing is based on intravascular injection, and we all hope we're not causing intravascular injection. But I think this is where it gets very challenging in conversations about how do we discuss what is the max dosing, or what do we think is an perhaps even different max dosing if the patient has hepatic, renal, or cardiac disease and may not be able to clear local anesthetics appropriately. I think that the next 5 years we'll see more and more discussion. Last in presentation is so variable, I have to imagine that it again is underreported. I recall as a fellow, we had a patient who came in, was having an AV fistula, and we had done the block under ultrasound, at which point the patient just started like staring off into the distance and the block never set up. And as my mentor at Michigan had said that oftentimes the presentation of LAST is tinnitus that's so severe that the patient can't hear what you're saying. And so I wonder how many times we think that the patient is just sedated from the medications we're giving to perform a block, and perhaps they have some indication of even just a low dose, LAST event. It's hard. I don't know that there's a great, number, like a magic number. And like I said, all of the data is highly variable insofar as what is the max dosing per the medications we give.
And there are different sites you're injecting
Different
them in.
sites,
Yeah.
different people.
I have another question for Dr. Hirschverdana. You mentioned the serratus block. Do you commonly do serratus block, or what patient population do you use that for? And I noticed on your slide, and this has always confused me, there's like a superficial plane that you can block and then a deep. Do you do both? Do you do one?
Usually, I haven't done them for breast surgery specifically, but in a patients with rib fractures, if it's an anterior fracture and I can't do a paravertebral, then I have done a serratus anterior block for that. Usually, I do the deeper injection at the level of the fifth rib in that plane, and usually it gets a good amount of spread to all the dermatomes.
And if you were to place a catheter for that, that's where you would leave the catheter.
Yeah, I think we haven't done too many catheters because it's kind of difficult to get it to stick there, but we have done a few catheters. Yeah.
I have also another question for Dr. Burns. You mentioned too, this goes back to nerve damage, nerve injury, like nerve toxicity. There are many different adjuvants and additives that we're putting in our single shot blocks now because we're trying to get them to last like as long as possible. Are there some that you avoid because of concerns of nerve toxicity or nerve damage?
Yeah, so the image that I showed is the good, the bad, and the ugly, and you can see that midazolam falls into the ugly, so I would never advocate, due to its neurotoxicity, that it be included in a perineural block. There is some data to state that some of the other medications, including epinephrine, right, if you're looking at a poorly vascularized nerve, and the one that most commonly comes to note is the sciatic nerve, that you should avoid using epinephrine in those injections. I have, in the very recent past, I've used clonidine, I've used dexmedetomidine, and at UVA, the majority of patients getting a single shot block get dexamethasone 4 milligrams perineural. So I feel comfortable with those medications, but also be very, very careful about when you are compounding medications in the sense that they need to be preservative-free. And so, yes, you may have clonidine available for intravenous injection, but it may not be preservative-free. And so I just make sure that you are, remaining vigilant that it is a preservative-free solution.
That's a really good point. I've recently started using dexmedetomidine and even considering now injecting it epidurally and intrathecally. And in that case, I was very concerned about preservatives and is our formulation that we're using preservative-free, because that's a really sensitive space to preservatives. And obviously there's a long history of issues with that.
I have a little bit of reservation about dexmedetomidine, and this is solely anecdotal, but we had a clonidine shortage at my previous institution, and so many of us, decided that we would try dexmedetomidine, and the patients were all profoundly bradycardic. And to the extent that the nurses in recovery were like, what are you guys doing differently? All these patients' heart rates are in the 30s and 40s. And yes, most of them were presenting for sports surgery, so they're otherwise healthy, and they probably had lower resting heart rates. But it just felt that there was some intravascular uptake or some involvement, even from a perineural administration. So just my little side anecdote about my experience with Precedex.
Yeah, I just had another quick question. You touched upon the intercostal brachyradialis block. Are people using that in an adjunct to, say, like a brachial plexus block for shoulder surgeries where they're doing the biceps tenodesis or AV fistulas?
Yeah, we're when we have AV fistulas, we'll supplement with the intercostal brachial nerve block. So either by doing a deep pectoral nerve block or just subcutaneous infiltration near the axilla. We haven't really been doing them for shoulder surgery. We don't have as much volume of shoulder surgery, but mostly for the AV fistulas.
Yeah, I think at my previous institution, we never did them for shoulder surgery, like open biceps tenodesis, and the surgeon did, infiltration. And my newer role, it's about 50-50 of the regionalists, to the extent that we actually are looking at whether, we should be doing it or not as a prospective study. Because I just don't think that there's great data to say, yes, you need it versus yes, you don't, and which patients. Often I just, have the discussion with patients that if they're going to have the biceps tenodesis, expect, pain in the axilla, kind of that burning sensation that many describe.
Yeah, I kind of find it interesting because a lot of my colleagues are transitioning towards doing both blocks, but I feel like my coverage for my blocks has been adequate. So I don't know if it's just kind of overkill or what kind of reimbursement people would get for that if it's really necessary. So that's why I was bringing it up.
Thank you to everyone for your questions and the discussion. Thank you to our distinguished speakers. And I would like to lead a round of applause here for our speakers.